Pinkee, and at the outset, I would like to thank Dr. Sharda Jain ma'am and Dr. Shashi for giving me this opportunity. So, I'm going to speak on blood component therapy in PPH. By now, we all know that whenever there is PPH, the first thing we have to do is to call for help. Dr. Sadhana Gupta has already elaborated that PPH is management of PPH is nothing but a team effort. So, after knowing all that, let's pause and let's think what exactly happens in a case of PPH. So, when there is PPH, there is more than 40% blood loss. Now, this blood loss will give rise to global hypoxia and a triad of hypothermia, coagulopathy, and acidosis. And this in turn can give rise to multi organ failure. So, our main aim is damage control by doing good resuscitation in obstetrics. So, how is resuscitation done? Ma'am has already covered. It is done by IV fluids and blood products. So, the crucial component in the management of PPH is blood and blood products. So, the question that comes to our mind is what should we transfuse? We all know that the blood is made up of plasma, WBC, RBC, platelets. So, component therapy is the way. Now, why component? A single blood donation unit provides treatment for 2 to 3 patients, and it avoids transfusion of element of whole blood that we would not like the patient to receive. The whole blood, the volume is around 450 ml and it's stored at 2 to 3 degrees Celsius in fridge, we all know. However, it's to remember that it does not contain any functional platelet and no labile coagulation factor in a stored blood. So when we want to give functional platelet and coagulation factor, we will have to give the component therapy. Now, pack red cell, it's available in 300 ml, again stored at 2 to 6 degrees in refrigerator, and 1 unit of pack cell increases hemogram by 1 gram per dl or hematocrit by 3%. Now, coming on to platelets, the common available platelet that we have in our hospital is random donor platelet. Now, this is obtained by centrifuge of a 1 unit of whole blood, and the amount that is there in that bag is 50 ml. At times where you have a good blood bank, there is facility of single donor platelet. It is done by apheresis of a donor blood, and it contains around 200 to 400 ml in one bag per se. So platelet, we have to know it's stored at 20 to 24 degrees centigrade and with continuous agitation, and it remains only life for 5 days. ABO compatibility is desirable for the platelets. Now, how much does 1 unit of random donor platelet increase the amount of platelet in our blood? It is 7 to 10,000, and a single donor platelet will increase platelet to the tune of 30 to 60,000. Now, here I want to emphasize that platelet transfusion is not going to be effective until we don't treat the cause, like ITP, DIC, whatever is ongoing cause, we have to first treat it. Fresh frozen plasma, it is available in a bag of around 200 to 300 ml, and we all know it contains coagulation factor along with fibrinogen. Now, it is prepared from separating from the whole blood, the plasma, within 6 hours, and then immediately you have to freeze to minus 25 degrees Celsius. And it can be stored for a year, but when you want to use it, it has to be thawed at around 30 to 37 degrees for 30 minutes. So it takes time for the fresh frozen plasma to be available. And once it is released by the blood bank, it's our duty to see that it is transfused within 6 hours. Otherwise, it is useless. It's just a bag of water. Dosage is around 50 ml per kg, and ABO compatibility is required. What I would like to stress here is fresh frozen plasma contains a lot of proteins. So you have to think twice. It gives rise to a lot of acute allergic reaction. So we have to assess, do we really need to give it? And if we require to give it, then we have to give it. Now, cryoprecipitate, it's nothing. The fresh frozen plasma, you precipitate it at around 4 degrees centigrade, and the precipitate you then resuspend in 10 to 20 ml of plasma. So it's nothing but fresh frozen plasma with a smaller content, that is 10 to 20 ml. Again, it contains more amount of fibrinogen and coagulation factors. The dose is 1 unit for every 10 kg of body weight. It is again stored at minus 25 degrees Celsius, and compatibility is required. Now the next question that comes to our mind is how to transfuse. So it's very important that we transfuse the right blood to the right person, and that also at the right time. Now clinical needs can be calculated depending on the blood loss. It will be covered in detail clinically and hematologically. We can decide that. So once we have decided that we need to transfuse blood to the patient, it's very important to take the consent for transfusion from the patient. Send the samples, and then the lab will send us the matched blood. But remember, the first thing we have to do once we have a blood bag in our hand is to examine the blood bag, which we all forget. We have to examine if there is any evidence of hemolysis, or it is or any other clots that are present, and if that is so, we have to discard it. Now record. So we have to check the identity, patient name, CR number, the blood group, and then record everything, all of the above, who is administrating and the time of administration. Monitoring is equally important. When we have to monitor, of course, at start of transfusion, 15 minutes, every hour, completion, and we forget, 4 hours even after completion of blood transfusion, we must monitor the patient because of the chance of delayed reaction. And how? Ask for the patient if she's having any complaint, monitor the vitals, and of course the input-output chart is very important in these cases. So I want to stress upon the time limit for infusion. Everybody just starts the blood bag and then they forget. It's not like that. There is a time limit with, you have to transfuse it. So I have mentioned the time limits. For the RBC, you start within 30 minutes and try and complete it by around 4 hours, maximum that also. Platelet, again, I have already said that, it is kept at 24 degrees centigrade with gentle agitation. So as soon as the platelet is, released, we must immediately, without wasting any time, transfuse this. Otherwise, it will be useless. Fresh frozen plasma, also, it should be transfused as soon as it's released, and try and complete it within 30 minutes. In extreme situations when, group specific blood is not available, what should be done? We give group O RH negative Paxils, and again I want to emphasize, consent of the patient is very important. You have to inform the patient, look, तुम्हारे unit का blood नहीं मिल रहा है, तो we would like to transfuse group O negative RH blood, because it will take time for the blood to be available. So does blood transfusion have any risk? Yes, it does have. Transfusion related, infection, immunological, all of us are aware, but the major risk of a patient receiving blood transfusion is incorrect blood transfusion. It's a human error that is responsible for major blood transfusion risk. So avoid unnecessary blood transfusion. Adverse effect, all of us are aware of it. Now the point comes how to manage them, So the first thing, stop the transfusion. Give antihistaminic, start IV corticosteroid. If the patient is having fever, give antipyretic. If she is having bronchospasm, give bronchodilator. Remember, then send the blood bag along with the patient's, freshly collected urine and new blood sample back to the blood bank. Let them evaluate why the reaction is there, and they will carry out a battery of tests. So how much to transfuse? The next question that comes to our mind. RCOG says for every 6 units of Paxil, we have to transfuse 4 units of FFP, and subsequent it can be decided with PT and APTT result. Platelet is to be transfused between 50 to 70,000 per cubic mm, and cryoprecipitate 2 pools, that is 5 units is to be required, and then we can transfuse according to the requirement. Now FIGO has published guidelines of postpartum hemorrhage 2020. So it says that resuscitation is either to be done by aggressive approach, that is rapid infusion of colloid, and now they recommend that hypotensive resuscitation approach should be done. Now why so? Because study has shown that administration of more than 4 liters of fluid is associated with more bleeding and adverse maternal outcome. So now there is a changeover. We don't have to rapidly rush the fluid. So the new guideline says that the hemostatic reanimation is based on early aggressive blood products replacement, and this replacement should be the tune of RBC, fresh frozen plasma, and platelet that is there in our circulating blood. So early administration of plasma within 3 hours is recommended, and ECOG also recommends administration to the ratio of 1:1:1, mimicking whole blood. So just a word about what is massive transfusion. Whenever we lose more than entire blood volume, that is 5 liters in 24 hours, or half the blood volume in around 3 hours, or some people consider it as 4 units in 1 hour and 10 units. So there is no there is no definition as such, but what I want to say here is why we have to know that have we done a massive transfusion or not, because we have to realize it gives rise to dilution, and dilution of more fibrinogen is seen in a PPH patient. So we need to replace fibrinogen more than other coagulating factor. So the FIGO recommends that the ratio of the packed cell to FFP to platelet should be 1:1:1, and after 6 units of packed cells and FFP and platelet, we must give 10 units of cryoprecipitate. So this is their recommendation for massive transfusion. Gold, Dr. Sadhana has already elaborated, so I will not go on that. And what I want to emphasize is the FIGO has also said, that these are good adjuncts to massive transfusion. So we have to give tranexamic acid and fibrinogen and cryoprecipitate, I already told, because in pregnancy we want to keep it more than 2 grams per liter, unlike other places where we want to keep it more than 1 gram per. So here I want to say why we have to know that we have done a massive transfusion. We have to be aware of what problems we can face: hypothermia, acidosis, hyperkalemia, citrate intoxication, and so on. So the take-home message is blood is an expensive and scarce resource. Safe blood product when correctly used can be life-saving. So the entire aim of this lecture is, making blood transfusion a very safe procedure. And thank you for your patient hearing.